Okay, what I'm going to do is I'm going to pass things over to Raymond and let him get started. Thank you so much.
Hey, everybody in Zoom land. Thanks for showing up. As you can see, my name is Raymond Moreland. This is Cervicogenic Headaches, and they are more prominent than the literature actually suggests. But before we get started, I just want to say a few things. I want to say thank you to Angela for setting this whole thing up and for listening to me practice a few times for a little while. Also, I want to thank ACAC and ChemStar for providing this forum so I could pass along some of the information to you all. What I'm going to talk about is basically a few headache classifications, literature that supports headaches originating from the neck, how the neck refers pain up into the head, muscle spindles, we'll talk a little bit about that, and a little bit about vestibular. Thankfully, I have a really good therapist out where I work right now, and Nox, who helps me differentiate between non-cervical and cervicogenic vestibular issues. All right. So a little epidemiology to begin with. 1 in 10 general practitioner visits and 1 in 5 neurological visits are for headaches. Headaches is the 5th leading cause of visits to the emergency department. Women are 2 to 3 times more likely than men to have headaches. And years of life with disability, migraines is ranked 8th. Classification. So in the literature has 2 different kinds of headaches. First one is the primary headache, which is 90% headache. So when you think of migraines, you think of trigeminal neuralgia. A lot of people have heard of occipital neuralgia, tension headaches, cluster headaches. Those are your primary headaches. Your secondary are the other 10%. In the category of 10% are the cervicogenic headaches. So I'm basically here to argue that that's a lot more predominant than the 10% suggests. All right, so this one is persons and all. This is, I'm trying to get through this as quickly as possible in terms of the literature, because it may not interest some people, but maybe some others. Basically, there are 275 people with cervical radiculopathy or symptoms going down the arm. And out of those people, 161 had headaches, mostly on the same side. They did a selective nerve root block on them, and 59% of the patients reported a 50% more in reduction of their headache. And of that, 69% reported total relief. So basically they went into somebody's neck, did a nerve block on one section, and these are the results they had. So they're going after the cervical radiculopathy or the neck pain and the associated arm pain with it. And they also had a positive effect on their headaches. Couple other people, Goatsby, I hope I'm not pronouncing that correctly. Basically, structures innervated by the cervical spine, which includes ligaments, disc, muscles, they're all established sources of pain. These structures can elicit pain along the trigeminal nerve, and I'll get into a little bit later about what the trigeminal nerve is, but more or less it just innervates the face. Gallagher, he's another physician who recommended that when you talk to their particular patients about their headaches, make sure you include an assessment of their cervical spine. All right, this is a clinic up in Ontario. Basically, they have approximately 800 patients per year. Obviously, it's a little fluctuation each year. But what they found is 80% of those patients were actually cervicogenic headaches and not the 10% or less than 10% that the secondary headache of the literature we talked about before would indicate. Centralization. So maybe you all who have been in PT before or have heard of things like sciatica. The McKenzie Institute, which is a well-known institute, has done a ton of research on centralization. Centralization, so if somebody has lower back pain and they have sciatica, the pain runs down the leg. So in the clinic, what I try to do, at least when I work with people, is I try to improve the symptoms that are farthest away. So if you have sciatica that runs down into the calf, my job is to try to figure out a position and or movement to improve that pain in the calf, not necessarily the back pain. If I can do that with any sort of consistency, then I can improve their back pain in the sciatica, or they have a higher chance of having a good outcome from conservative care. So what myself and a number of other people have worked on is improving or centralizing people's headache symptoms. And I'll go over a map. I'll have a little map later on which shows how to centralize somebody's headache symptoms and refer them back to where they're originating from. But before I get to that, another little research by a gentleman named Bogduck. He subjected these poor people to noxious stimulus up in their neck. So the upper part of the neck is kind of the very top, right below the base of the head. And then as you go down, it's C1's the top one, C2 all the way to C7. So for the people who had it up in the top, I don't know, I hope you all can see. Basically, very at the top of the neck, 85% of the people felt it up in the front part of the head, 70% in the eye, 65% in the temporal region. Now, as you went down, as you kind of notice, the symptoms refer less up into the facial region. So if you have a neck problem and it's higher up, it's more likely to refer down to even the cheek, teeth, gum, mouth area. If it's a lower cervical spine problem that is referring pain up into the head, you're less likely to have these symptoms in the face and more typically in the back part of the head or maybe the side. I'm gonna get a drink of water real quickly. Trigeminal nerve. So I briefly touched upon this before. So if somebody has a neck problem, it can refer into the trigeminal nerve area. So that can be the forehead, the cheek, the jawline down in here. All right, so this is a kind of a simplistic version of what's going on in your neck. So I'll try to cover it. This is basically somebody's neck. So this is their C1, again, that's the top part of the neck. C2 is a little lower down, and C3. So this is basically in your spinal cord. What this is I don't know whether you guys remember from biology, maybe back in high school or college, where you had cell bodies and then you had axons coming off of that. So the axons are the nerve endings. So if you touch up in the forehead, you have nerve endings up there, and the cell body of that nerve is actually located in your spinal cord along C1 to C3. You also have nerves coming in from the top part of the neck up top here, C2, C3. You also have your vagus nerve. So let's say you have a really irritated neck, and it's coming from the top part of your neck, and it's sending all this information going into your neck, and you're a lot of signals coming in there saying, I have pain, I have pain, I have pain. If you have so much pain, sometimes your brain just has trouble interpreting the information. So it may interpret that you have a little bit of nausea, the vagus nerve, which goes down to your belly. You know, you have that nauseous feeling. Sometimes people even get sick. You also have your trigeminal nerve, so you can feel it up into your head region. Anyways, there's just, again, there's some sort of confusion as to where the pain is coming from. Similar to, well, actually, I don't know much about heart attacks, but if you feel in the arm, that is referred pain. If you're having a heart attack, you'll feel in your left arm. That is referred pain. You don't necessarily have something wrong with your left arm. Same sort of idea here. If you have a neck problem, sometimes you can feel it in different areas. All right. This is sometimes I give this to people who have headaches in multiple areas, and I try to communicate to them that they always want to pay attention to the symptom that's furthest away. So if you have a problem in your neck, it can refer pain. The next area would be area 2. Now, I don't see a lot of area 3 and 4, which is kind of the ear and then right in front of the ear. Oftentimes, your headache will just kind of go from here, and it'll kind of head forward and up this way. And like that Bogduck said, if you have a problem in the upper part of your neck, you're more likely to get symptoms up in this area. Versus if you have it down further in the neck, you're less likely to have 9, 10, and 8 area, and more likely just to have this 2, maybe up to the 6 area. I give this to people. I try to produce or change their symptoms in the clinic, show that there's basically some sort of consistency with either their posture or their environment, which is causing their symptoms to move around their head. All right, dysfunctions of the upper cervical spine. Basically, how do we all get these problems in our neck? Well, I'll give you one clue. It's this thing right here. Another clue is computers. We have whiplash injuries, stress, inflammation, all of these areas. It briefly talks about this altering muscle spindle sensitivity. So muscle spindles, what is a muscle spindle? You know, when you go to the doctor's office and somebody hits you right below the kneecap and your leg kicks out, that's basically muscle spindles in your patella tendon. So you have your patella tendon, somebody comes in there, hits it really quickly, it causes an elongation of that tendon. Your body goes, ah, it sends that kind of signal, goes up to your spinal cord. Since it happens so quickly, your body really didn't like it. It does a protective mechanism, causes your quadricep to contract, your leg kicks out. So you have a few muscle spindles down there, but you have a much larger portion in the upper cervical spine. So if these muscle spindles are activated by other, again, inflammation, too much stretching, like we talked about with your patella tendon, you hit a quick stretch. If you're on your phone for extended periods of time, especially some of the teenagers out there, not my kids, of course not, you know, or you happen to be sitting in front of a computer and your neck's like this, and you're typing away, and your head is getting worse. Those muscle spindles get irritated. Sometimes they can cause inflammation, or we also talked about, you know, motor reflexes. Actually, I had somebody on my schedule today, nice young lady, who fell over because she had got an ear piercing and kind of got faint and nauseous, fell over. And next thing you know, she's having all these vestibular symptoms, which I should go to the next slide. All these vestibular symptoms, the dizziness and kind of confusion and having trouble with, I guess, the area around her moving. But again, I've got a great colleague of mine who helps me out, figure out basically if somebody's having vestibular symptoms or dizziness or the room spinning. She helps me figure out, again, and Nox, she helps me figure out whether basically they're cervical involvement or whether they're non-cervical involvement. She takes care of all the non-cervical involvement. And if she feels like it's possibly a cervical spine problem, then I get to see them. Anyways, what I do in the clinic when I see somebody, the first things what I do is I watch them. So they're usually out in the waiting room. And like I said, I even caught a few of them on the second visit with one of these things looking down. And there's the little verbal chastising that goes on, hopefully jokingly to some point, but a point behind it. Anyway, so I bring them back, I ask them all sorts of fun questions, and we talk over, you know, when it started, what happened, what seems to make it worse. Usually the response is, I don't really know what makes it worse. But anyway, so I'm watching the posture constantly and seeing how they sit. So the first thing I do is I kind of sit them up really nice and tall, and not only just tall through kind of the shoulders and the back, but also pull the head back over the shoulders. Then I basically have them sit there for 30 seconds and say, okay, did it change? You know, did the headache move? You know, first of all, I get some indication as to where their headache was initially, change their position and see whether it moves. If it moved, let's say they had started with a headache in the back and all of a sudden it went, and I make sure that it was in the front part of the head, and all of a sudden now they feel something in their eye. So that's based on that map that we did before. That's the symptom that moves from here and that moves further away, which means your neck is not very happy about, and that was a worsening of pain. We talked about those little muscle spindles before being up there. So if you take, and I'm going to put my fingers on the back of my head, and hopefully you guys can see it. So that's C2, that's the back of the head. If I sit up tall, my fingers separate. So you take that area and those muscle spindles, which are a little hyperactive at this point, and you stretch it for 30 seconds. The neck muscle is not going to like that because we just talked about how it's doing that protective contraction, and it causes the symptoms to peripheralize or head away from where the problem area is. On the other hand, let's say if they have a lower cervical spine, I consider the lower cervical spine from C2 down. So again, that's C2. Sorry about, I hope everybody's close enough. And that's C7. That's the lower cervical spine. If you put that in better alignment and their headache is originating from them, their headache will actually improve, meaning it'll move from, say, again, the front part to the back, or maybe it doesn't move, but the symptom that's furthest away will decrease in intensity. Perfect. So anyways, I think that's it for my lectures. Oops, yes, it is. So I can open up this for questions now, for anybody who has questions, and Angela is going to do a really great job of helping me out because I probably should get my glasses out to see the questions. You see the first one?
Well, we don't have any yet.
Oh,
please feel free, for those of you who maybe joined on after, If you want to, in just the little chat area at the bottom, you can kind of write in any questions that you might have.
I'll get some water.
Okay.
It went so well that I answered all the questions.
Oh, wait, here we go. Have you noticed any relation between cervicogenic headaches and photophobia?
Yeah, so any sort of visual problems, yes, that can, I think under this next section, it does talking about extraocular muscles and is responsible for clear vision while moving your head. So that can be affected. That's more along the vestibular line. This talks about keeping a stable position of the head while the body is moving. So that helps with the neck and the vestibular symptoms. Now, actual photo visual eyeballs, visual stuff, I have had people complain of things that are floating, that kind of float across their visual field. I hope that explains your question. And usually, you know, again, if somebody has a symptom and they have it right there in front of me, there has to be some sort of consistency with, you know, doesn't improve, does get worse, doesn't improve. And if you change somebody's positioning, doesn't make a consistent change in their symptoms.
Okay. Can you mention other symptoms that may, oh, sorry. No, why is it not? There we go. Sorry.
That's all right.
Okay. Can you mention some other symptoms that may be associated with this? Light sensitivity, sound sensitivity, etc.
I haven't had a lot of sound sensitivity. I would call it tinnitus. I've had that, which is that area 3 in the inner ear. I have had that. And what was the other part of that?
It was sound sensitivity.
A light sensitivity.
Yeah.
Yeah, people complain of wanting to be in a dark room all the time. So that's usually associated with your migraine symptoms. People like to turn the lights off and turn the sound down and retreat to the room. So yes, I have seen that before.
Okay. Difference between cervicogenic headaches and occipital
Well,
neuralgia.
that's where, again, the occipital neuralgia is what they consider one of those primary headaches. That's the 90%. I think it's a lot higher than the 10% of the secondary headaches that we talked about. I think a lot of it is coming from the neck, so I would put that in the cervicogenic category, mostly with occipital neuralgia. Next one.
Oh, yeah.
Usually it depends on what the patient comes in with. So if they come in with, and usually it's the physician who has a good relationship with a therapist. So if it's a vestibular symptoms and the physician wants to send them, they usually send them to Anne at the clinic. Anne will run through her vestibular symptoms. It could be BPPV, and then she'll resolve that symptom. If Anne then feels like she got that referral and it's not necessarily something and it's more cervicogenic related, then she'll send them to my schedule. Vice versa, if I get somebody who comes in and has vestibular symptoms and I think that's not coming from the neck, I'll push them off to Anne and Anne will take care of them.
The next one is what can they do at home to help prevent or relieve neck tension that causes headaches?
Well, I would say it's hard for me to tell you what to do because so many people have different presentations. Like again, I can't even tell people to sit up nice and tall. Typical 20 years ago was, well, if you have a neck problem, sit up nice and tall. Well, again, some of those upper cervical spine headaches, and actually that's how I kind of got involved with this 20 whatever years ago. Was I was at a course and my father had headaches, my brother had headaches, my sister had headaches, and I had headaches, and so I was like, oh, okay, well, I'm going to sit up nice and tall. I had a miserable headache that night. So that was kind of the lead into how I kind of got into this. And how to treat somebody, I can't even tell you whether you should be sitting up tall or not, because it actually may make things worse. So I could answer those questions better if I knew what kind of headache you have. Sorry. Pillows. All right. So yes, one of the things I ask for people who wake up with headaches, I don't think it's really a pillow per se, because let's say you have a neck problem and it's exacerbated by holding your head down like this. So maybe you do a lot of typing or whatever the case, and it typically gets worse. So if you sleep like this, I don't care where you got your pillow from, you're going to have a headache in the morning. So that's one of the questions on my evaluation is I ask people, how do you feel when you wake up in the morning? Do you have a headache? And if so, is it all over the head? Is it typically better? If you went to bed with a headache, do you typically wake up and it's better in the morning, or is it typically worse in the morning? And also, you prone sleepers, you will eventually come to see me, I believe, anyways, because basically you're taking your neck and you're hanging it out in range of motion. That's going to be really uncomfortable to lie like that for 6 hours. I mean, if you think about trying to, let's say, hold your elbow at end range of motion for 6 hours, it's going to get a little uncomfortable, right? So for all belly sleepers, it's just a little warning. You may want to get off of it, particularly if you're waking up with headaches in the morning. But that is something we do address, and we talk about tracking your symptoms. If you wake up and they're worse in the morning on average, then what position are you waking up in? And I basically break it down into 3 sections. If you're on your side, it's kind of 0, 1, 2, and 3. So finding out what position they're in, whether they wake up on the right side, left side, back, and then what are their symptoms when they wake up in those positions. There's about a 75% correlation, meaning, you just got to roll over, 15 minutes ago, and yet for the previous 3 hours you were on your belly with your head turned to the left, then you're going to get incorrect information. But if you more or less, if you wake up and 75% of the time you have a miserable headache if you wake up on your belly, then yeah, it's your belly. It has nothing to do with your pillow. All right. So if you have someone whose headache gets worse when they sit up tall, what sort of exercises, therapeutic strategies do I use? Since the upper cervical spine is has so many muscle spindles, what I found what works is not my hands. It's kind of, took kind of a few years to figure that out, but that typically makes it worse because they're so sensitive. So 8-10 years ago, I took this course on dry needling, and that's a different lecture. You can all look it up if you want to. Basically, it's using acupuncture needles to put into the upper cervical spine of somebody's neck at particular points. I put them either face down or on their side, put the little needles in there. If they do not have a pacemaker, I will attach a little electricity to it and leave them there for 25 minutes. It does a really nice job of getting those muscle spindles to relax and get to their baseline. It's kind of like if your computer's on a glitch, you just shut it off and turn it back on. So it really works well for the upper cervical spine.
Okay, so this one.
Oh, I missed one?
Well, it's okay.
Okay.
It scrolled up. Fairly mild, but and then do they need a headache when evaluated?
Well, I mean, that's up to you if you want to do a headache evaluation. I mean, you would have to come and see me. If they're very mild, it depends on how badly you want to come in and what it means to you. I mean, if they're bad enough where you want somebody to evaluate you, I'd be glad to do it. If you feel like, I can just live with it, fine, they just pop up every once in a while, then that's fine. You can live with your headache.
Do they need to have a headache at the time of the evaluation?
It is helpful. So it's kind of like if you take your car to the shop and it makes this bling, bling, bling noise, and the guy looks at you like, where's it coming from? It is helpful to have a headache. So what I do sometimes is I tell people, all right, if you have a headache, give the office a call, come on in. I'll do my best to kind of fit you in at the end of the day, as long as I don't have to get a kid anywhere or something like that. And I'll do my best to come in and see you that day. I can make educated guesses, but it's only based on, okay, somebody can't right rotate as much as they can left rotate, then you're probably looking at C1, C2. And then we talked about, if your symptoms are more in the face, you lack a little left rotation versus right rotation, and that typically comes in the upper cervical spine, then you've got 2 things that say it might be coming from the upper cervical spine. But I can't be 100% sure. So it is very helpful to have the headache.
Okay. The next question, it seems that jaw issues could also mimic cervicogenic headaches, since the TMJ can also lead to some similar symptoms into the face. Do you end up leaving or having to work with TMJ treatment?
I typically am pretty I don't do a lot of TMJ. And maybe that's something I should get better at. Maybe I'm going to do it in the next 5 years or whatever. But I would say if you can change somebody's neck position and cause area, 4 to improve, then, just by changing their neck position, then it's probably not coming from the TMJ joint. If they are like a true just TMJ, they don't have any neck pain and I can't change by moving their neck around, I can't change this symptom, then it's not coming and they should just go see a specialist in TMJ.
Yeah, which we have some.
Yeah, and then ACAC has got plenty of other therapists to help you out in that department.
Headaches worse.
It gets worse when they sit up tall. Yeah, I did that one.
Okay, so here's another one. My mother was diagnosed.
Yeah.
Okay. With neurogen.
Drink a cup of caffeinated coffee. All right, well, good luck going back to sleep. Or going to sleep prior to bed. Eek, gosh. Not that I'm going against any physicians. But yeah, 3 a.m. in the morning, that sounds like if it is a cervicogenic headache, it's probably the position she sleeps in. Maybe she's on her side and she doesn't have her neck supported. Maybe, like I said, she's sleeping down like this and all of a sudden, the neck gets tired, those muscle spindles fire. They send out all that information to that trigeminal cervical nucleus and it starts to refer pain up into the head. So we work on sleeping posture. Jokingly, I tell people if they lie on their belly, put a thumbtack there. Not really. I tell them to put like a tennis ball there, strap it to their chest, or maybe half a tennis ball that keeps them off their belly. Or if they don't like, or they get headaches when they sleep on their back, we'll put a half a tennis ball on the back of their back. That usually will keep them off that particular part of their body. Other exercise you can run? No.
Sorry. One thing that I like, we talked about posture and holding your head back like this. If you exaggerate that movement, that's what we call a chin tuck or cervical retraction. People give it all sorts of fun exercise like the chicken exercise, the turtle exercise, but all it is it's stretching the upper cervical spine and it's putting the lower cervical spine in a more straightened out or less flexed position. So depending on what segment you're on. If it doesn't change your headache after doing like 20 repetitions of that and changing your posture, you may not have a cervicogenic headache. That exercise sometimes makes people better and sometimes makes people worse. But eventually, if you have an upper cervical spine headache, you do need to gradually introduce that type of movement so your neck is more tolerant. But it's almost like if somebody, let's say you break your ankle and you get a brace put on it, that's not the time to start doing vigorous exercises, right? You want to basically get the thing to heal, increase the tolerance to weight bearing, increase the tolerance to maybe walking, then eventually running, and then maybe running is an appropriate thing. But, early on, it may be the actual wrong thing to do.
Okay. All right.
Thank you. Got to go. All right. Well, have fun at dinner.
Okay. All right. Oh, do you use traction for headaches?
No, I try to teach people, yes, you can use traction, right? And it'll provide for the lower cervical spine headache, will provide relief for 45 minutes. But what happens on Saturday when I'm not there and the traction table and everything's locked up? So I try to teach people, most importantly, and I try to do as much communication as possible to help people have an understanding of what makes it better, what makes it worse. So if you get stuck on a Saturday, your appointment's not till Tuesday and it's Monday and you have a really bad headache, you can do things on your own to help improve them. So that's one of the things I do. I do a lot of talking. I tell people what's going on, how to make it better, how to make it worse. So they can become their own therapist and eventually they can say bye-bye to me and take care of themselves.
Do you like to have people use double tennis balls?
Okay. The suboccipital muscles. No, the suboccipital muscles, now there are a few outliers which do like massage or self-massage to those using tennis balls or whatever up in the upper cervical spine. But for the most part, they do not want me touching their upper cervical spine. I literally can take my fingers the other day, held it in somebody's upper cervical spine, left it there for 10 seconds, and they got those vestibular symptoms, and it just started going around. So
The last thing they're wanting to do is start sticking tennis balls down there. Now, again, doesn't mean that there's not exceptions to the rule, but that's in general what I find. Now, the lower cervical spine, it is difficult to get that area up there with those, just because you have that curvature right along there, and it's hard to get in there. But if it works and it helps your headaches and you find that it consistently does it, I'm always about, if something works, do it. And make sure you can do it as much as you can to improve your symptoms without making things any worse. Okay.
All right.
I guess, thank you, everybody.
Yeah.
Have a nice evening. And
wonderful questions. Thank you guys so much. This has been recorded, and so we will be putting the recording on our YouTube channel, and I will be sure to send it out to everyone who's here today. So thank you.
Thank you.
All right. Bye.
Thank you.